want handouts made that were, well, I certainly didn't want handouts made that were 4 slides per page because I didn't think you'd be able to see very much if the images were that small. Plus, the images aren't in color, so it just seemed to me much better if you would use your laptops. The PDFs are enabled so that you can type right over the images. So if possible, I would prefer you did use your laptop. We're trying to be green as much as we can. If there are students who really want printouts, I suppose we can make separate arrangements. I don't want to print out 240 and then only 50 get used. But if you do feel strongly that you would want a hard copy, let me know, email me. I know now my box is going to be full of 200 emails, but email me and let me know, and then we'll work something out and prepare handouts for those students who really want a hard copy. All right? And then the other thing is that the clinical lectures, such as the one we had this morning, will always be posted online. But if the clinician doesn't give it to me ahead of time, I can't post it ahead of time. So I'm hoping to get Dr. Feldman's lecture for tomorrow, this afternoon, and I will post that one. And I will be posting the radiology lecture this afternoon now that I have it. And then finally, after I finish speaking, Dr. Barazow is going to talk just for 5 minutes. He's going to, he and his colleagues are doing a, I believe, a cricothyrotomy demonstration in the laboratory today, and he wants to just orient you briefly to what you're going to be seeing. Obviously, you don't know much about the neck yet, and I told him that, so he'll keep it simple. Okay? Yeah? Right, the M2s and D2s do not come to lab today. I spoke about this a little last time. Obviously, the M2s and D2s are responsible for what's being taught today. So you have to learn it some way. Okay, one way would be to have your alternate group, your M1, D1 group, teach it to the M2, D2 group. You could do it however you want. You could also do it with friends. That's okay too. It doesn't have to be the alternate group. But I think the process of teaching it is a very good exercise, because if you can teach it to someone, then you really understand it. So I would suggest doing it that way, but who you choose to do it with is up to you. And definitely you need to meet before Thursday, because you can't walk into Thursday's laboratory if you don't understand what was done today. All right? And the Thursday group, or the Tuesday group, has the weekend to do that. Okay, so you can do it any time before Tuesday. Okay. Oh, now one other thing. Yeah, no, I'm up to the lecture. Last year, students but said that they were not able to see the pointer when we used when we used a laser pointer on the slides. Is that true? Has that been a problem already for you guys? Okay. Because seeing the pointer is sort of crucial in anatomy. So someone is loaned me a super duper, one of these new really strong laser pointers. So I'm going to use it for a few of the slides today. Yeah. Yeah, I know. I use it. I guess I'm not sure. Is the echo a video of the screen? I thought it was a. No? Oh, all right. Then I'll use the mouse pointer. Okay. I sort of hate doing that because I feel like I'm not lecturing. I feel like I'm talking to the computer. But anyway, I'll do that then. All right. So today, what I'm going to do is start by giving you an overview of the body wall and the upper limb, which of course is what we're going to be doing in this block. And then about halfway through, I'll switch and talk more specifically about what you're doing in lab today, which is the pectoral region and the flexor arm, or the ventral compartment of the arm. Oh, hold on. All right. So as I told you last time, the body wall is composed of the trunk and the extremities. And what you're seeing in this image, which is a sagittal section, a mid-sagittal section through a person, is that everything you're seeing in this picture is essentially body wall. So, well, of course, you don't see the limbs, but you see the trunk, you see the head and neck, and that's body wall. Also notice that there's certain internal structures. This is the diaphragm, which separates the thoracic cavity from the abdominal cavity. That's also part of the body wall. And I'm making that point because its innervation is going to be similar to the innervation of the body wall. So, but this gives you a very accurate depiction of what the body wall is. The muscles in it that you're seeing now, the pecs and the biceps, those are made up of skeletal muscle. You probably realize there are different types of muscle. The cardiac muscle is what makes up the heart. And then there are structures that have smooth muscle. And those are smooth muscles found in most vessels. It's also found in basically most of the GI tract, and the urinary system is made up of smooth muscle in the walls. So, but the pecs and the biceps are all skeletal muscles. All right, so I normally start a region by going over some embryology. Understanding the anatomy of the region it's very helpful if you have a start with the embryology. So what I want to talk about a little bit is how the limbs develop, and that will help you understand why they're actually part of the body wall. So what we're looking at here are two early embryos, the 4th week of development. That's the 4th week after fertilization. And what you see is that on the side of the embryo, a bulge starts to appear, which is actually going to be the upper limb. And then a little bit later in development, the lower limb bud appears. So if we're looking at an embryo straight out, let me just show you. So if we're looking at an embryo from the front, like you're seeing there, we're seeing an embryo like this, with the bulges growing, eventually elongating into limbs, both upper and lower limbs. And what you're seeing in this picture is the fact that embryos, and you and us, we're all segmented. We're segmented with respect to the nervous system, as well as to the musculature. And as those limb buds elongate and grow, they are carrying or maintaining the segmentation that they had while they were still part of the trunk, essentially trunk. The embryo, as it's starting, is essentially a simple cylinder, and the limbs grow out from the cylinder. Now, if we look at the limbs in cross-section, here you see a cross-section through an embryo's limb. What you notice is that, and this would be through the forearm section, because we have two bones. We have a bone here and a bone here. What you see is that if we divide the limb into a ventral section and a dorsal section, that there's a muscle group in each section, and that the muscle group is innervated by a nerve that is different from the nerve that innervates the other section. So these compartments are established very early in development and explain why the muscles of the ventral compartment of the arm that you're seeing today are all innervated by one nerve, and the muscles of the posterior compartment of the arm are innervated by a different nerve. Also, if we look at the arm or the limbs in terms of their transverse border, divide them transversely so that we're dividing it into a superior part and an inferior part, what you see is that as the limb grows out, the palms, for instance, and the soles of the feet are facing forward. So the superior part of the limb bud is going to become thumb and big toes, and the inferior part is going to be where the little toe and little fingers are, okay? And also the bones, everything is going to be with respect to, if you imagined yourself with your legs and arms out and palms and soles forward. So as I said, as development proceeds, the limbs start to elongate, and by this point you're already seeing that there are two discernible regions, the arm and the forearm, and the hand region starts to flatten out, and there are regions that thin, these are called digital rays. They're the first indications of where the fingers will be, And the cells between within these thinned out regions continue to die until we end up with actual fingers. This process is known as apoptosis. You've probably heard of that already. And this is cell death, but it's naturally occurring cell death. It's cell death that's supposed to or always happens in development. Okay. Now, if that does not happen properly, you end up with a situation where two toes or two fingers can be fused together, and that's a condition known as syndactyly. And then the final thing to happen in limb development is that the limbs actually rotate, and they rotate in opposite directions. So what we have is the upper limb rotating outward, and the inner limb rotates inward. So that what we're left with is an elbow when flexed points backward and a knee when flexed points forward. Okay, and that's because they rotate differently, the upper and the lower limb. Now, as a result of that rotation, what you have is a certain amount of movement, essentially, of the compartments as well as of the segmentation. So in the terms of the surface innervation, for instance, in the lower limb, notice how it spirals. It's much more of a rotation than in the upper limb. But in the upper limb, if we look at a cross-section through the forearm, what you see is that in this situation, the extensor compartment, which goes all the way up to here, the extensor compartment is wrapped around partially to the ventral surface. So that's explained by the fact that that limb has rotated. Now, the body wall is innervated by the peripheral nervous system. The peripheral nervous system is made up of cranial and spinal nerves. Cranial nerves are those nerves that exit from the brain, and you're seeing them here on the base of the brain. You will see them much more in the second block, and these do not innervate the upper limbs or the trunk region. So we're not going to be talking, except for one exception, we're not going to be talking about the cranial nerves. The spinal nerves are nerves that exit from the spinal cord, and they are responsible for the innervation of the extremities as well as the trunk region. So we're going to spend a lot of time talking about the spinal nerves. Now, the central nervous system, just to be clear, is made up of both the brain and the spinal cord. Everything external to the brain and the spinal cord is part of the peripheral nervous system. So I don't know how many of you saw nerves last week. Did any of you get to see what a nerve looks like? All right, good. Well, if you didn't see it last week, you'll see it today. And I think one of the surprises is that nerves are really macroscopic. In fact, a lot of the nerves you're seeing are probably about the size of a piece of spaghetti or even thicker than that. And when we get down to the lower limb, a nerve like the sciatic nerve can be as thick as a marker pen. So we're talking about really things that are substantial and relatively big. So what we're looking at here is a slice through a nerve. This is kind of like a salami slice. So what you're seeing is that the nerve is made up of a whole bunch of axons. And these axons are cut in cross-section then in this part of the image, and you see the fact that they're longitudinally oriented in this part of the image. The nerve is also contains connective tissue and blood vessels. So those are all contained external to the axons, but the axons themselves are bundled into fascicles, and there's connective tissue between the fascicles and external to the fascicles. So nerves are a living tissue that need blood supply. We're not going to be dissecting those vessels because for the most part they're microscopic, but you should realize that they're there and that indeed the nerve is getting a blood supply. Now, a collection of axons within the PNS is called a nerve. If you have a collection of axons in the central nervous system, it's called a tract. Okay, so it's really not different in certain senses. It's still a collection of axons, but I just wanted you to realize that when we say nerve, we're talking about axons that have to be in the peripheral nervous system. And any nerve that you're going to be dissecting will be containing both motor and sensory axons, or axons from motor or sensory neurons. One example of sensory innervation would be from the skin, and an example of motor innervation would be, for instance, to skeletal muscle. I want to just talk about the general nature of both sensory and motor neurons. And this is what I would call a typical sensory neuron. These cell bodies are within the peripheral nervous system, therefore they're going to be in a ganglion. And the ganglia you're going to be primarily dealing with in this block are the dorsal root ganglia, and we'll talk more about those on Thursday. But the cell bodies of these neurons are unipolar, that is, they only have one process emanating from them. But they have, you see that it bifurcates quickly, so we have information coming back from the periphery, such as from the skin, and going into the central nervous system. Okay, so these neurons do not have synapses within these ganglia. They have the process synapse. There's an effector structure at the peripheral end, and of course synaptic endings at the central end. A neuron that has a signal coming toward the central nervous system is referred to as an afferent neuron. Okay? It has, just as with the term medial or lateral, you have to say what it's afferent to. And we don't always say it when we're talking about neurons, but when we say afferent neuron, we mean that that signal is coming back toward the central nervous system. Okay, and here you see in a sort of light microscopic drawing the skin. Here you see the fat or the superficial fascia, and you know already that you're going to be able to see veins in the superficial fascia, but I told you that there are no visible arteries or nerves. Well, that doesn't mean they're not there. Oh no, there are cutaneous nerves that are visible, but the arteries are very tiny and not dissectable, and the nerves are. But they all go to supply the dermis of the skin. Now, besides skin, you may not have thought about it, but we also get sensory information from skeletal muscle, tendons, and joints. And what that allows us to have is the sense of proprioception, which means that we know what our body position is without seeing it. So I know, that my fingers are wiggling up there even though I don't see them, and I know my elbow is flexed and so forth. So all of that information is relayed by these afferent sensory neurons. Now, motor neurons can innervate skeletal muscle, and these are the ones I'm going to talk about first, or they can innervate smooth muscle, cardiac muscle, and glands. So first I'm going to talk about the motor neurons that innervate skeletal muscle. And you'll see sometimes these are referred to as motoneurons without an R, that's not a typo. And these are also referred to now as efferent neurons because the signal is going away from the central nervous system. Okay, so we have a cell body now, which, first of all, the morphology of the cell looks very different from the sensory neuron. It is what's called a multipolar morphology because it has multiple processes. It has one axon, which is typically very long, and a cell body that has numerous dendrites emanating from it. And this axon then terminates on skeletal muscle, whereas the cell body is located in the spinal cord in a specific region called the ventral horn. So these cell bodies are within the CNS. So imagine you have a cell body within the spinal cord along your back somewhere, and that axon has to go all the way down to the little, the foot to wiggle one of your little toes. Okay, so these axons are incredibly long with respect to the size of the cell body. When that axon gets to the muscle, when those axons, you have a group of axons in this nerve, and when the branch gets to the muscle, they're going to divide up. And individual axons or groups of axons are going to go to individual muscle cells. And the group, in other words, the number of muscle cells that are innervated by any one group of axons is referred to as the motor unit. And, the size of the motor unit is indicative of the control that we have over that muscle. The more motor units, that is, the more axons innervating the muscle, the finer control we have over that muscle. So today, well, as we go through this block, think about it. When you see the branch of the nerve going to the biceps, it's not that different in caliber from the nerves that are going to the hand muscles. Okay, so the hand muscles have a much greater number of motor units, which is required for the dexterity that we have in our hands. Now, the other group of motor neurons are actually also called the autonomic nervous system, and they innervate smooth muscle, cardiac muscle, and glands. Now, I'm only going to talk about, at this point, the smooth muscle, targets of the autonomic nervous system that are in the body wall. I'm not going to talk about the organs or the heart at this point. So within the body wall, we have smooth muscle, which is primarily within blood vessels, or all the blood vessels, most of the blood vessels, but there's also some smooth muscle in the skin. Each hair is anchored down by a tiny muscle called an erector pili muscle, so that when you're cold or scared and your hair stands up, it's the erector pili that are contracting and doing that. Now what you'll notice first is that the innervation of these targets is very different from the skeletal muscle, in that instead of having one neuron that directly goes to the muscle to innervate it, we have two neurons in series. So we have what we call a presynaptic neuron, and then the second one is called the postsynaptic neuron, and then the axon of the postsynaptic neuron is what ends or it directly innervates the smooth muscle or glands. The glands are sweat glands that we have in the body wall. Now, these presynaptic neurons are located in the central nervous system, also in the spinal cord, and we'll talk about more specifically later. But they're therefore located in what we would call a nucleus. A nucleus is a collection of neuronal cell bodies in the CNS. A ganglion is the term we use for a collection of cell bodies in the PNS. So the first neuron in the series is in a nucleus. The second neuron, because it's in the periphery, is in a ganglion. Also notice that the first neuron, the presynaptic neuron, is myelinated, and the second postsynaptic neuron is not. Myelination you'll learn much more about later, but it's a fatty coating on the axon that helps propagate the signal and make it faster. Okay, so we have three divisions of the autonomic nervous system. You probably, I'm sure, all know about the sympathetic and parasympathetic divisions, and most of you haven't heard about the enteric nervous system yet. Okay, have you had Dr. Gershon yet? Well, that's his life's work, is the enteric nervous system. So that's part of the autonomic nervous system that's within the gut. It's confined to and innervates and helps innervate the gut. So I'm not going to talk about that today, since we're going to talk about that when we get to the gut. The other two systems also innervate different structures. The sympathetic system is really found everywhere. It goes to the body wall, in other words, trunk, limbs, head, and it also goes to the viscera or organs and to the genitalia. But notice the parasympathetic system. It only innervates organs, the head, and genitalia. So therefore, I'm not going to talk about the parasympathetic nervous system yet. It does not innervate the body wall. Only the sympathetic nervous system does. Okay? So what is actually the way we distinguish the two systems? Most of you probably heard, well, one speeds up the heart, one slows down the heart. But the actual reason for differentiating them is the location of the presynaptic neurons. So in the case of the sympathetic system, the presynaptic neurons are in the spinal cord, in the thoracic region and part of the lumbar region. And the parasympathetic system is located, the presynaptic neurons are either in the brain or the part of the sacral part of the spinal cord. So they each have very specific locations within the central nervous system. So what I'm going to talk about more specifically then is the sympathetic nervous system and how it innervates the structures in the body wall that it innervates, that is smooth muscle and glands in the body wall. Since it's the sympathetic nervous system, the presynaptic neurons are in the spinal cord, specifically from T1 down to L2. Okay? If we were looking at cervical spinal cord, we would not see any sympathetic presynaptic neurons. Again, everything I said before holds. These are both multipolar neurons. The presynaptic axon is myelinated. And the postsynaptic neurons that innervate the cell body are located in something called the sympathetic chain. And the sympathetic chain runs along either side of the vertebral column. So they're also sometimes called paravertebral ganglia. That means next to the vertebral column. So essentially, what this means is that for the most part, the presynaptic axon is going to be relatively short, since it's not much of a jump from the spinal cord to the sympathetic chain. And the postsynaptic axon is relatively long, which is why I've sort of made a dashed line there. So the neurons I've talked to you about are classified in we use certain nomenclature to classify these neurons, partly because it's easier to talk about them just with initials, but also because certainly you'll encounter this nomenclature as you go ahead in your careers and on the boards. So the sensory neurons are called general afferent neurons because they are coming from all over the place and they're sensory. So they bring sensations, in the case of the body wall, from the skin, such as touch, temperature, and pressure, and they bring sensations from muscles, tendons, and joints. Then we have the group of neurons, motor neurons, that innervates the skeletal musculature. And these are called general somatic efferents because they are all over, they are motor, and they are innervating the soma, which is another word for wall, so body wall. Now the next name doesn't make sense, okay, so you'll have to blame those anatomists from long ago, don't blame me. All right, but the sympathetic axons that we're going to be seeing in this part of the course are called general visceral efferent neurons. Okay, they're called general because, again, they're all over, efferent because they're motor, and they're called visceral because they do supply the viscera, but they supply a lot else besides the viscera, so it's really not a good name. I don't know. It should be like somatico-visceral efferents or something, but whatever. But anyway, GVE always refers to an autonomic neuron. And in the case of the simple body wall, we're talking about sympathetic neurons. And it's supplying motor control to smooth muscle and glands. So I wanted you to just think about what kinds of axons are in what nerves that you're going to be seeing in lab. You won't see it today, but soon you'll see a spinal nerve before it branches. Okay? And if you look at a spinal nerve, any of the spinal nerves, before they branch, what you'll understand is that they have all three types of neurons, GA, GSE, and GVE. Okay? And what I want to talk about then is what happens as that nerve branches. Today you're going to see branches going to the muscles, specific branches. So you'll see a branch to the biceps, a branch to the brachialis, and so forth. And you'll also see branches, cutaneous nerves, and you're going to see, not today, but you'll eventually be seeing some nerve, probably to joints or bones. So which of these are going to have a sympathetic component? Okay, well, basically all of them are, because they all have blood vessels. There are blood vessels in the bones and joints and so forth. There are blood vessels in the, certainly in the skin, and there are blood vessels within the muscles and tendons. So all of these nerve branches are going to have a sympathetic component, and those axons are going to be postsynaptic, okay, because they've already synapsed in the sympathetic chain. We'll be talking much more about this as we go along, so I know it's a lot that I'm throwing at you today, but it will be repeated, trust me. Again, there is never a parasympathetic axon in a spinal nerve. Okay? None of the branches of the spinal nerves ever have parasympathetic axons. All right, well, what about sensory? Again, every branch of every spinal nerve has a sensory component. In terms, we already talked about the proprioception. So we have afferents from the nerve, joints and bones, and from the muscle and the tendons. and also from the skin, the cutaneous nerves. So you may read in certain books that people will call a cutaneous nerve a sensory nerve, and I hope that after today's lecture you'll realize how wrong it is to call it that. Okay? It's not just sensory, it also has a motor component. And the same is true for nerves that innervate muscles and tendons. Those are not, it's not appropriate to call them motor nerves because they also have a sensory component. And then only the branches that go directly to the skeletal muscle are going to have the GSE component, right? There's no skeletal muscle in the skin, there's no skeletal muscle related to the bones and joints, so there's no need to have a GSE axon there. Okay, so only the nerves that go to the muscles and tendons have, or to the muscle actually, has a GVE component. Okay, so now I'm switching gears to talk about today's lab, but again, just starting with sort of an overview. The upper limb, I already talked to you about this last time, how you have to be careful now about your nomenclature. And the other thing that we'll be talking about is, or I think especially it'll be apparent when we get to lower limb, but the two limbs are very different in their mobility. And the upper limb is extremely mobile. I always forget who this is. I know it's the closer. Rivera? Yeah, all right. But anyway, you can see how mobile his upper limb is. And that's as a result of the types of joints, the morphology of the joints, and we'll see that as we go along in the shoulder region. And then again, we have great dexterity in the upper limb that we don't have in the lower limb unless, I mean, I've seen people paint and play piano with their feet, but most of us can't do that. So again, that's related to the motor units that I already spoke about. So let's first talk about the skeletal makeup of the upper and lower limb. Well, the skeleton by now, I think you're probably pretty familiar with it just from high school. But certainly you know each limb has a single bone in the initial segment and two bones in the more distal one. And then the hands and feet have many bones that we'll get to later. But the skeleton that comprises the limbs, and we call that the appendicular skeleton, includes more than just those bones. For the upper limb, where it also includes the clavicle and the scapula, and for the lower limb, it includes the two pelvic bones. And the reason for that is they are essentially part and parcel of the upper limb and move along with the upper limb, which again we'll cover much more in the future. But they are really part of the upper limb, and this is called the pectoral girdle. Down here is referred to as the pelvic girdle. And the rest of the skeleton then is called the axial skeleton, and it consists of the vertebral column, the ribs, and the skull. Okay. So in today's lab, the other thing to realize, which I think is kind of amazing, is that the two skeletons, the axial and the appendicular skeleton, are joined together by one pair of joints each. So in the case of the upper limb, we have this joint between the clavicle and the sternum, the sternoclavicular joints. And in the case of the pelvis, we have the sacroiliac joints. Okay. These are both actually synovial joints, that is, they have the capacity of movement, but the sacroiliac joints really don't move very much, and they have a very big surface. And these two joints are really tiny and extremely mobile. So doesn't it surprise anyone that that's the only bony connection of the arms to the, or not arms, the upper limbs to the rib cage or to the trunk? I think it's pretty amazing. So what we're going to be learning about is how the upper limb actually stays on then, right? Because there's a whole series of muscles that connect the upper limb to the axial skeleton. And it makes sense then that we call these axio-appendicular muscles. They're going from the axial skeleton to the appendicular skeleton, which helps support the limb as well as move the limb. So in the case of the pectoralis major that you're seeing today, now you see how it comes from the ribs and the clavicle. Well, it comes from the ribs, and then it attaches, well, this part of the pec major attaches to the ribs and then to the humerus. So that's axio-appendicular. This part of the pec major is actually totally appendicular because it's going from the clavicle to the humerus. Okay? So we'll see that in more detail in a minute. Now, just thinking about, you have to start thinking about what movements are possible at each joint. And the shoulder is actually made up of 4 joints, and we'll talk about that more next week. But of course, you know how mobile the joint is, that you saw with Mariana Rivera. But the movements you can make with the upper limb are really combinations of 3 pairs of movements. Okay, the first one that's easiest to understand is abduction and adduction. Okay, so think of when someone is kidnapped, they're abducted. Okay, so you're taking the arm, the upper limb, away from the trunk. And a deduction then is the opposite. You're bringing it back to the body. Like when you adopt a child, you're bringing it into the family, right? Okay. Then we also have rotation, and that's rotation of the humerus with respect to the scapula. So you really have to sort of bend your elbow to prevent the forearm from moving. But you can see that you're really moving just the humerus when you do this. Okay, so that's medial and lateral rotation. And then the last thing is flexion and extension. Okay. So these movements, when you combine them in all different ways, provide a lot of different movements of the upper limb that are really not named. Circumduction is, and that's sort of when you turn, do this. But that's a combination of everything. Now, we also have movements at the elbow. The elbow is a relatively simple joint. It either flexes or extends. And then there are 2 other movements that are possible because there are joints between the radius and the ulna in the forearm. And these are called the radio-ulnar joints. And I'm mentioning this because you're already going to start seeing some muscles that cause this, that cause this movement. And essentially, if you look at your hand in anatomical position or your forearm in anatomical position, you'll see how the ulnar and the radius are not crossed. They're parallel to one another. So this is the position of what's called supination. And when we turn the palm to face posteriorly, we're in pronation. And when you're in pronation, the bones are actually crossed, although it's not that apparent when you're looking at your forearm. Now, I want you to put your hand on your elbow, fingers on the tip of your elbow. That's your ulna. That's part of the bone, the ulna bone. Now, go from, I guess you could keep it on. Go from supination to pronation. Does anything happen to your ulna? No. And by the way, this is a good example of bringing your body to the museum. Right? You're allowed to do that. All right? So the only bone that moves during pronation and supination is the radius. And you can see that in this picture that it's only the pinkish bone that moves, not the ulna. The other part of that is that in order for a muscle to pronate or supinate, it has to attach to the radius. Okay? It seems obvious, but that's the case, right? If it attaches only to the ulna, it's not going to cause pronation or supination. Okay, so today in lab, you're starting where you left off, and essentially you were skinning the pectoral region and arm last time. And most of you, I believe, left the breast behind. The breast is within the superficial fascia. A long, long time ago, I heard Margaret Mead lecturing, and she called the breast a modified sweat gland. So, I remember that to this day. It was probably 40 years ago, but I thought it was so funny. But anyway, no, she called it a glorified sweat gland. That's what she called it, a glorified sweat gland. Okay. Anyway, the breast is really, the breast is really composed not of glandular tissue that makes the milk during lactation, but it also is made up of fibrous tissue and a lot of fat, or depending on the size of the breast, a variable amount of fat. In this individual, the skin has been removed and the superficial fascia removed from the remainder of the chest wall. So you're seeing the breast by itself. Also notice that part of the breast actually extends into the armpit or axilla, and that's called the axillary tail. And when you examine a breast, it's very important that you continue that examination under the armpit to feel the entire breast during an exam. In this case, we're looking at a section, a sagittal section through the breast, probably in a lactating woman, because the glands are drawn very big. They're blue here. And the milk then is supplied or is carried via a duct system to the nipple. Now, there is connective tissue between these glands, which are called the suspensory ligaments of Cooper. They run between the glandular tissue and attach to the dermis of the skin. And one of the reasons that breasts tend to change their location as someone ages, you're probably not aware of this yet, okay, but those of you who have happened to see someone a little older than yourselves will notice that there's drooping of the breast. And that occurs because these ligaments start to just break down. And especially women who don't regularly wear bras, that is going to happen quicker. Okay, so, but there's nothing pathological about that. But what can happen within the breast is that if there's a tumor, it can pull on these ligaments, and you end up with a dimpling. You can end up with a dimpling of the skin as a result. So if you ever see a dimpling of the skin like that, it's a cause for concern, and certainly you should follow up with a patient that shows this. So once you've looked at the breast, and probably in lab you're not going to see very much because I believe for the most part these were elderly women, so it probably won't be that satisfying in terms of seeing ducts and glandular tissue. But once you've tried to do that, you'll remove the breast from the body wall and clean your pectoralis major so it looks like this, right? You want to see the muscle, and you want to see the inferior border of the muscle, and you want to see the border of the muscle from the deltoid. Right? And here we see the cephalic vein, which is a very good landmark because it does separate the pectoralis major from the deltoid muscle. Now, you also should come across some cutaneous nerves that pierce through the pectoralis major fairly close to the sternum. So the pectoralis major has two parts. In this picture, you're seeing it diagrammatically. They're showing you the direction fiber and the attachment sites. It has a sternocostal part that comes from ribs. Costal is ribs, sterno is sternum, and that goes to the lateral lip of the intertubercular sulcus. And then we have the clavicular head that goes from the clavicle also to the same location. So there are two heads, and this picture is nice because it allows you to imagine what happens when the fibers shorten. It's drawing you essentially the directions of pull that occur when the muscle contracts. Again, you should always know attachments of muscles and actions. We do not use the term origin and insertion because that term was developed because the origin was defined as the stable part and the insertion is the movable part. So if you're looking at the biceps, for instance, this would have been the insertion, well, you know, where it attaches superiorly would have been the insertion, and where it attaches inferiorly would have been, I'm sorry, the origin's up here, the insertion's down here, okay, because the insertion's moving, right? But what if you're doing a chin-up? Then suddenly it's the proximal part that's moving. So it really doesn't make a whole lot of sense to differentiate, and in certain circumstances it becomes complicated, so we don't care if you know the difference. We just want you to know a proximal attachment versus a distal attachment. Now, one thing that the pectoralis major demonstrates is an important concept, and that is that muscles can have multiple actions. I think probably most of you realize that. But also, different parts of a muscle can have different actions. So in this situation, if you look at the clavicular head, its action is flexion at the shoulder. It's not a very strong flexor, but you can imagine that if it contracts, it's going to help a little bit in flexion at the shoulder. In contrast, the sternocostal head is an extender, does extension at the shoulder from a flexed position. And again, if you think about the attachment of the pec major, that when it contracts, it's going to pull back on the arm. All right, so that's an important concept that we'll be seeing again and again. And then here you see that they do have actions, similar actions, that is, they're both adductors and medial rotators. Okay, now again, I think it's pretty obvious that there'd be adductors when they contract and this shortens. And medial rotation is also something you can figure out if you think about it, because they're attaching relatively lateral on the humerus. So when they contract, they're going to grab the lateral part of the humerus and bring it medially. Okay, so again, these are examples of why I don't want you memorizing so much. I want you to think about it and have a way in your brain of figuring it out without memorizing it. All right, so in lab today, you're going to be cutting the proximal attachments, not the distal attachment, the proximal attachments, and reflecting the muscles away from the midline. Okay, so before you do any cutting, you have to make sure that the borders are clean and that you can put your hand underneath the muscle, particularly the sternocostal head, and free the muscle from the body wall before you start reflecting. Now, another caution is that there's a lot of what we could call goodies in this region. So before you start reflecting, you want to be really careful. Here you see the clavicle, this would be the clavicular part of the pec major, and there are all these vessels and nerves that come out there. So you want to be very careful not to injure those as you're reflecting. And once you've reflected the pecs, you're going to see the innervation to the pecs on the deep surface, the medial and lateral pectoral nerves. And you can't reflect this far over until you've sort of cut out a little button of muscle to keep the nerve and to sort of remember what that nerve went to. But we'll show you that in lab. So deep to the pec major, which you see over here, we have the pectoralis minor. Again, you're reflecting it from its proximal attachment and reflecting that superiorly. That's a muscle that it goes from the ribs to the coracoid process, and therefore it's axio-appendicular as well, and you're going to cut it off of the ribs. There's another muscle that you should try to see, the subclavius. It's not labeled here, but this is the subclavius. It's a very, very thick muscle and very important in stabilizing this the sternoclavicular joint, because it attaches to the sternum. It attaches to the first rib and then to the clavicle, but essentially it's still very important in stabilizing that whole region. Okay, and then finally you're going to go to the arm. Now the arm is pretty simple in terms of anatomy. We have a superficial muscle, the biceps, which has two heads, a long head and a short head. By the way, the attachment site of the pec major is over here. So that's why you have to reflect the pec major away from that in order to see the structures deep to it, particularly the heads of the biceps. Okay. If we look at the biceps again, there are two heads, one that's called the short head that goes to the coracoid process, and one that's called the long head. And people always think it's reversed in lab, but the long head is lateral, and it also disappears under the joint capsule of the shoulder. So it's going to go a long distance to the top of the supraglenoid tubercle of the scapula. And the biceps, again, is interesting because it has different actions depending on the forearm's position. So if you think of it the normal way, kind of, it's attached via a tendon to the radius, okay, to the superior part of the radius. There's another part called the bicipital aponeurosis that I'll mention in a minute. That's a flat tendon that goes into the deep fascia. And that's, so aponeurosis is just a term for any flat tendon. But the part that's going into the radial tuberosity is on the anterior part of the radius. So when the muscle contracts, it's pulling on that radius and causing flexion at the elbow. And here you see the relationship of the bones and the fact that the forearm is in pronation, in supination. So, but if you pronate and you have the arm extended in pronation, then suddenly the radius has rotated as a result of pronation, and that tuberosity is all the way on the posterior side. So when you're pulling, the biceps is still causing flexion, but it's also causing supination as you're flexing, okay? Because it's pulling on the radius to get that radius by contracting, it's pulling on the radius, and it rotates back to the front. Okay, so the anterior compartment of the arm has deeper muscles to the biceps. That is the coracobrachialis, and here you still see the pec major in place, and the brachialis. And you can study those on your own. The anterior compartment of the arm is all innervated by one nerve, as I said earlier. It's the musculocutaneous nerve. And you see that nerve, it pierces through the coracobrachialis. It then sends branches to all these different muscles, and it continues finally as the lateral cutaneous nerve of the forearm, otherwise known as the lateral antebrachial cutaneous. Now, something that is also an important concept is that although the muscles of the anterior compartment are all innervated by the musculocutaneous nerve, that's not true of the skin. So if you look at this picture, I'm showing you there are several different cutaneous nerves that actually innervate that skin. The musculocutaneous, the lateral femoral cutaneous from the musculocutaneous is shown here in green. So it innervates a little bit of the cubital fossa, but basically it's doing the forearm skin. Okay, so that's something also to keep in mind, that even if you know the muscular innervation, you don't necessarily know the cutaneous innervation. The vessels you're seeing today are primarily going to be the brachial artery, and hopefully if you get down to the cubital fossa, it's bifurcation into the ulna and the radial arteries. The axillary artery becomes the brachial at the lateral border of the teres major, but you're not going to really see that today. You'll see that more on Thursday. I want you to start thinking in 3 dimensions. And if you look at this cross-section through the arm, it's sort of similar to what you're seeing here. This is a more 3D picture. But you see the biceps is more superficial, the brachialis deep to it. There's no coracobrachialis because we're too inferior on the arm. And you see the musculocutaneous nerve going between the biceps and the brachialis, and that's very typical. And here in the cross-section, again, is the biceps and the brachialis. And then you see the brachial artery, which is in the medial part of the arm. You see that this is where the neurovascular bundle is. And you see that here. And there are other nerves in the arm that you're going to see, but they're not innervating anything in the arm. They're just using it as a throughway to get to the forearm or hand. All right, so you are going to see the ulnar and median nerves, but that's not part of today's, not seeing what they're doing yet. And again, this picture is put up in the way that we display CAT scans and MRIs. That's always the way we're going to show any cross-sectional image, and Dr. Lignelli went over that with you this morning. So you're always going to look at that arm or any structure as though the patient is lying in the bed. So in this case, if the patient's lying in the bed, this would be the right arm, right? And this would be lateral, and that would be medial, anterior, posterior. And you should, as you get better in anatomy, be able to figure that out even if I put it up randomly, because you should know, for instance, that that neurovascular bundle is medial. Okay, and then this is a picture I really want you to study on your own. It's a really pretty netter picture that shows you a typical cross-section in the upper part of the arm, the middle, and the lower. And I want you to just think about what you're seeing and how it's changing as we get more inferior. Okay, so if you understand this picture, you will certainly understand what you did in lab today, what you're going to be doing in lab today. Okay, and part of the reason also for understanding where these things are located, of course, is to know where to put pressure if you're trying to compress the brachial artery. Okay, so